I have no conflicts of interest with the KCM or the Sepsis Alliance, and nothing to declare. I have no connection with any pharmaceutical company on this regard during this lecture. This is my roadmap. So, what is sepsis? The definitions already that have been discussed, but few points I have to mention. Sepsis is characterized by the life-threatening organ dysfunction due to a dysregulated host response to infection. What does that mean? It is not a bad infection. It doesn't say the infection is bad or not, or the magnitude of the infection or the coloniform of the infection. It is just said the dysregulated host response, and is the response, body's response, and sorry, antibiotic alone will not fix the problem. This is the professional narrative from definition of sepsis 3. Septic shocks is a subset of sepsis where the particularly profound circulatory, cellular and metabolic abnormalities, which substantially increases the mortality. Now, a patient initially, when a patient comes to emergency department, we are getting unclassified patients. The patient coming with hypertension could be anything, as Dr. Mahin said. Important thing, we have to screen the patient with the context of presumed or confirmed infection. Sepsis 3 recommend, you might have heard about Q-SOFA before, against using Q-SOFA compared with SIRS, NEWS or MUSE as a single screening tool. As Dr. Mahin clearly mentioned, there is no single screening tool for us to diagnose sepsis. If the NEWS score or early warning score is more than 5 or above, and patient looks unwell to a clinician or the carer, and the patient who had recent chemotherapy or immunotherapy and has a lactate of more than 2 or above, you need to have a high degree of suspicion. Could this be a sepsis? Risk factors, very young patients and also very old patient is a risk factor. And people who have impaired immune system because of the illness or drug are vulnerable to develop sepsis. There are so many risk factors: cancer with chemotherapy, impaired immune function like in diabetic patient, long-term steroid patient with immunosuppressant drug, and the surgeries or invasive procedures done recently, and breached skin, and the indwelling lines or catheters. Those are risk factors. And also pregnancy-related factors. Could it be a peripartum cardiomyopathy coming with low blood pressure to emergency department? Could it be a puerperal sepsis? Or could it be a just simple myocarditis? How do we identify, how do we screen the patient? So once we screen the patient, next thing, looking for an organ dysfunction, whether this patient have an organ dysfunction or not. Right. There are high risk criteria. That is a national early warning score 2, which consists of respiratory rate, saturation, pulse rate, blood pressure. I think Dr. Anurudh Aryans will talk about it later. And you can use the systemic inflammatory criteria, SOFA, National Early Warning Score, and Modified Early Warning Score to identify whether the patient has organ dysfunction or not. Right. Important clinical tip is clinical judgment should always come first. This is not the scoring, and this is the clinical judgment. And if you have a clear alternative cause, consider alternative course of action. Right. Patient coming with fever, having low blood pressure, could be due to myocarditis. Patient coming with fever and low blood pressure, could it be due to an anaphylactic shock after taking an antibiotic? Which we don't know. And likewise, so if you have a clear-cut alternative pathway, consider the patient to alternative course of action. But if patient is at risk, don't hesitate to start treatment for sepsis. There's a pre-hospital bundle which was discussed in Sepsis 3 guideline. What's the pre-hospital bundle? Where you work in a peripheral hospital, start the resuscitation at peripheral hospital setting. Just give oxygen to maintain the saturation more than 94. And normal saline, 250 normal saline bolus if patient is normotensive, and normal saline up to 2 liters if patient is hypotensive. And the communication with the pre-alert receiving hospital emergency department or ICU or medical ward or surgical ward. This is very important, and proper clinical handover. There are risk assessment tools. Moderate risk assessment, which is if the new score is 5 or 6, with O new score is 1 to 4, this will be discussed. I'm just going through. The patient is having mottled skin and non-branching rashes, cyanosis. These patients considered as a moderate risk. So what you have to do, send the full blood count or VBG and consider discussing with a senior doctor or consultant, and if microbials, antibiotics are needed, you have to start antibiotics. The high-risk patients, yes, in high-risk patient, you have to initiate a sepsis 6. There are 6 components that you start immediately. First, ensure senior clinicians attends because it's a clinical judgment. Second, give oxygen. Those are simple things but prevents death. And obtain IV access, take blood culture for glucose, lactate, full blood count, urine electrolyte, and clotting profile. And give antibiotic, start source control. And IV fluid up to 30, can give up to 20 ml per kg, but we can extend up to 30 ml per kg. And the monitoring. You can't just start the fluid and antibiotic, you can wait until patient transfer to somewhere else, so patient don't expect the patient recover. Continuous monitoring is important, which prevent death. Right. So in survival sepsis campaign, they talk about the hour 1 bundle. It's not 1 hour bundle, it's hour 1 bundle. Right. Important thing is the hour 1 bundle, measurement of lactate level is important, and obtain the blood cultures before administering antibiotics. But make sure if you can't take the blood culture, that's okay, you can start antibiotic. And antibiotic should be a broad spectrum antibiotic. That depends on the infection varieties. What I do is, depending on the patient clinical setting, I contact my microbiology colleague. That is the usual practice in our emergency department. Because I'm not the expert, but antibiotic should cover the infection and hit hard and fast. And rapid administration of fluids, 30 ml per kg crystalloid, the patient hypertensive or lactate level more than 4 millimoles per liter. And the apply vasopressors to keep the mean arterial pressure more than 65. Right. Just a little bit of lactate. Everybody's talking about lactate. Make sure lactate is not a diagnostic tool of sepsis. There are 2 types of lactate. Type A, primary due to tissue hypoxia. That's we are talking about cardiogenic shock, sepsis. You get the type 1. And type 2 is the presence of adequate tissue oxygenation, but with the impaired lactate utilization or excessive production. It could be due to liver failure, renal failure, diabetic, metformin, beta agonist, or the toxins. So you have defined in sepsis, these type A and type B interconnected. And the lactate, importance of the lactate, sometimes you'll come across a patient, blood pressure is normal. Patient is having fever, bit tachycardic. Lactate level may be high, 4. But blood pressure normal. That is the impending septic shock. We call it cryptic shock or occult septic shock. That is one of the markers to identify that patient might go into a septic shock in next few hours. And it's a predict outcome. High lactate means high mortality, and also it helps guide the therapy, the lactate. So that is lactate. I just want to talk about the time 0. What is the time 0? So everybody talk about 3 hour bundle, hour 1 bundle. What is the time? Where do you start? Where do you calculate from 0? That is patient first meet the criteria for septic shock, indicating that the healthcare provider believes that patient has an infection. It could be in the emergency department triage or maybe in a peripheral hospital doctor. He decided this patient has sepsis. You have to consider that as the time zero and calculate from that time up to the 3 hours or 1 hour. Right. Now, fluid is important thing. Fluid and heart in sepsis, right? In a healthy heart, like you and me, maybe I may not be, but it's a major determinant is the stroke volume. Major determinant is the preload for you and me. The preload is the major determinant. In a patient with heart failure, afterload is the major determinant of the stroke volume. It's the preload and the afterload. Right. In a sepsis, sometimes you will come across a patient with heart failure. The afterload is very low. Why? Because in sepsis there is, as Dr. Mahen mentioned, there's intense vasodilatation and so is the leaking. So afterload is very low. So for the patient with cardiac failure who develops sepsis, the contractility becomes the main determinant of stroke volume. Keeping in that mind, you have to do the fluid resuscitation with a septic patient. Right. What is the aim of fluid therapy? To correct the absolute or relative hypovolemia. Initial stage of sepsis, you might see, is a relative hypovolemia, not the absolute hypovolemia. So some sepsis patients, they have the absolute hypovolemia as well. And bring the patient to the normal pulse rate and blood pressure and mental state and the lactate. That's the aim of fluid therapy, and avoid pushing the patients to a overload. So you have to have a very fine balance. There's the two entities called warm sepsis and the cold sepsis. What is warm sepsis? In early stage of the sepsis, because of the vasodilatation, your peripheries are pink and warm and increase the heart rate and cardiac contractility. So you might not think that this is not sepsis because his peripheries are warm, patient doing very well, but you won't worry about it. But that is warm sepsis. And the next moment, within our body tries to compensate and the peripheries become cool and clammy and CRFT become more than 3 seconds. So that is a cold sepsis. So you have to start the patient. You don't need to wait until the patient blood pressure drops. So there are many ways and means of assessing your volumes in the emergency department. Right. The fluid choice is the crystalloid are the preferred first line treatment for fluid resuscitation. The normal saline and Hartmann saline or balanced solution, that is plasmalite, we don't have in our emergency department. And also the sepsis guideline 3, they recommend the albumin. Because albumin stays predominantly in the vasculature, and you have to consider giving albumin when you are going to use a large volume of crystalloid for resuscitation. Consider about albumin, but it's very expensive. Right. How to guide fluid resuscitation? There are dynamic parameters in emergency department or any ward, now ICU. One thing you can do is the response to a passive leg test for fluid and the stroke volume variations and pulse pressure variation and echocardiography. You can use the ultrasound probe and see the echocardiography contractility of the myocardium and whether the IVC collapsible or IVC dilated, and depending on that we can guide a rough idea about the fluid management. And to prevent overload in emergency department, what we do? So we have given fluid. If you have given the fluid, but still the patient is not picking up mean arterial pressure up to the level, to decide whether we have to go for another fluid challenge or fluid bolus, we use the lung ultrasound scan and to check whether there's a B profile coming. Even the patients having fine crepes, lung ultrasound scan shows the B profile. Until we appear the B profile, we can give the fluid bolus in emergency department. Right. What is the rationale of research? It had been discussed by Dr. Mahen. So this is the problem with the tank, pump and the hose pipe. There is the preload, afterload and the myocardial contractility. In severe sepsis, preload is also, tank is empty, afterload is reduced and because of the cytokines and everything, myocardial contractility, there's a myocardial depression. So these three are interplay. Right. This is the recommendation of fluid resuscitation. Early aggressive fluid resuscitation to correct hypovolemia improve the outcome. Early aggressive, I will explain later. And initial volume of fluid, the adult patient to use 500 normal crystalloid, using it within 10 to 15 minutes. And this is the important thing. But what we try to do, give a fluid bolus, ask the nurse to give fluid bolus. Then when nurse asks, doctor, how fast should I say? You have two options. Either you have to mention correct time, or you have to ask the nurses, do as you are doing in the earlier days. Issara karawagi karagane anda. Or you have to specify the time if you don't know the answer. But the answer is you have to complete it 10 to 15 minutes. And maximum volume is 20 ml per kg, but you can extend up to 30 ml per kg. Why do we need to give rapid fluid bolus? That is because there's a fluid leaking from the peripheral vasculature. As Dr. Mahin mentioned, now your rate of giving fluid is lesser than the rate of leaking. Is no point giving fluid in a 30 minutes or 45 minutes or 1 hour. It has to be given within 15 minutes. Right. So when the fluid management, now resuscitation done, your blood pressure has not come up, patient still having low blood pressure, you have to fix it. Then you have to consider starting vasopressin. I'll talk vasopressin later. The target of fluid resuscitation, increase the systolic blood pressure more than 90, and normal conscious level, respiratory less than 25, lactate level 2 less than or 2 less than 2. It is, you can't achieve the lactate level 2 millimole, but if it is a downtrend, that is has to be accepted. This is what I want to discuss. Fluid, first fluid fast, second set slower. If you come across a patient with cardiac failure, you need to give some fluid. It may not be 500 milliliter. This is a practical thing. So it could be a 250 milliliter. Because you are reluctant, just looking at the patient may be fail, but you say 250 milliliter, this patient is overloaded, 250 milliliters, give in 30 minutes or 45 minutes as I discussed. Don't do that. That is okay. Patient is heart failure, but if you want to give a slower volume, don't reduce the rate of fluid infusion. That dose should be given within 10 to 15 minutes. Because otherwise, you can't balance the fluid leaking and the fluid infusion. Then you can prevent the shunting of blood as well as you can improve the peripheral perfusion. Then you can see the response, fluid response. Otherwise, you can't see the fluid response after giving fluid bolus over 1 hour. Right. Antimicrobial, I have not going to discuss too much. For adult suspected sepsis shock, yes, you have to start empirical antibiotic. So unconfirmed infection, you can start antibiotic and re-evaluate. Please contact your microbiology colleague. And alternative cause of illness is strongly suspected. You can discontinue empirical antibiotics. Probably after emergency department, go to the medical ward, the physicians, they look at, they assess the patient. If they want to de-escalate, they can de-escalate. And for adult with low likelihood infection, differing antimicrobial, starting of different, but they recommend. You don't need to start antibiotic. Right. So this is the chart which have been given. So if the patient is shock is present and sepsis is definite, you have to start antibiotic within 1 hour. And sepsis is possible. If the patient is shock is present, still you have to start antibiotic within 1 hour. And shock is absent, you can consider starting antibiotic up to 3 hours. You have a grace period, another additional 2 hours to start antibiotic. That is, sepsis is possible and patient is also not in shock. So you have started we have given fluid, we have screening done, organ assessment done, we have started fluid, started antibiotic, and fluid is still not response. So we have to go for active agent, that is norepinephrine. I think we have to start norepinephrine, but you don't need to start CVP line. You can start from the peripheral line. Up to 6 hours, you can send norepinephrine through a peripheral line. So norepinephrine, once you start norepinephrine, you can keep on increase. If it is more than 0.5 microgram per kg per minute, you can't increase furthermore. You have to start vasopressin. Vasopressin is not titrated to the response. It is 0.03 units per minute. That is fixed amount. Okay, and it also fail. You can start epinephrine, but make sure patient might develop arrhythmias. Right. So we have started vasoactive agent, but still the patient's blood pressure is not picking up. What about starting inotropes? Sepsis-induced myocardial dysfunction is recognized as a major contribution for the hemodynamic instability. I think ICU doctors and consultants discuss more about this, but in emergency department, inotropic therapy can be used patient with persistent hypertension after adequate fluid resuscitation and patient with cardiac dysfunction. What I'm going to start adding dobutamine to norepinephrine or using epinephrine alone. That is the recommend. So patient is on noradrenaline, you can start dobutamine if you think that the patient having cardiac dysfunction. Right. Then the source control, 3 minutes more. Source control, that is, yes, that depends on the anatomical site of the infection. We have to call the surgeon or physician or gynecologist. Unfortunately, in emergency departments, all the disciplines are sometimes pediatric. Involving, so I have to keep on calling everybody. A vascular surgeon, so vascular surgeon is not my field, so refer to the surgeon, and those things are coming, but this is a teamwork. And source control is very important. We have to control it within 1 hour, right? Additional therapies. IV hydrocortisone, dose of 200 milligram per day. Give as 50 milligram intravenous as 6 hourly or as a continuous infusion. When do you start hydrocortisone? Is it within 1 hour or 3 hours? No. Ongoing requirement of epinephrine or norepinephrine. Norepinephrine is more than 0.25 microgram per kg per minute for at least 4 hours of initiation to maintain the mean arterial pressure more than 65 mercury millimeter. Then you have to start steroid. Probably I don't start in emergency department, but it is after seeing the response. It's not in the bundle. Right. Glucose control. We try to control blood glucose if it is more than 180 milligram per deciliter. 1 minute more. And the disposition, yes. So that depends on the patient's new score parameter, whether to go to the ward, whether to send the patient to the ICU. Finally, my dear friends, ladies and gentlemen, it's a teamwork. There are no heroes in managing sepsis. You have to be a part of this team, a member of this team, to become, which consists of physician, surgeon, gynecologist, pediatrician, and the vital role played by microbiologist. Or you have to be if you don't want to be a part of this team, you have to be a part of this team, just looking at the patient. Nothing you can do. So you have to actively participate on the first group. Take home message. Early identification and appropriate management in the initial hours after development of sepsis improve the outcome. And clinical judgment should always come first. Implement of dynamic measures to guide fluid resuscitation over physical examination and static parameters are recommended. Administering antibiotics immediately, ideally within 1 hour of recognition, possible septic shock is recommended. Finally, is a multidisciplinary approach, no individual heroes. Thank you very much.